Hi, I'm Frank Vocci, and I'm going to be interviewing Dr. Vania Apkarian, who just presented in a session on opioids at the ASAM State of the Art meeting. Dr. Apkarian, would you describe your research in chronic pain?
So we do human brain imaging studies, in fact, together with animal models where we try to replicate some of the results that we find. Basically, we're looking at the properties of the brain, both its anatomical and functional properties, how they are different in chronic pain conditions versus healthy subjects. And more recently, we've been looking at subjects who are becoming chronic pain, or transitioning from an acute pain state to a chronic pain state, and how that transition actually, what is the physiology, the neuroscience, the neurology of that transition.
You say, what have you found?
So we've described in the past that the pain of chronic pain has multiple signatures in the brain, and in a sense, it seems to be unique for different types of chronic pain conditions, and uh, that signature is coupled with unique reorganization of the brain anatomy, primarily the gray matter local densities, which we think is a measure of the extent of synaptic reorganization of the cortex, which is then reflected in the functional differences between different chronic pain conditions. So that's for the chronic pain state in a sense, and our more recent work looking at the transition from acute to chronic pain shows fascinating new ways of looking at what chronic pain is specifically. Basically, we see very strong brain anatomical signatures that differentiate people who are becoming chronic pain patients versus people who are recovering from the acute episode of back pain. And in a sense, what is surprising is that all of these patients begin at the same duration and intensity of pain and emotional anxiety and depression, yet half of these people become persistent with their pain over the year, or even now we have data over multiple years. And their brain is continuously changing. You can see that there is now anatomical changes in their brain together coupled with functional reorganization. But most importantly, we see a very strong brain anatomical signatures that show that these people are already vulnerable to become chronic pain patients a priori before the injury, essentially. And the surprise is how strong those signatures are in that just the brain and atomic white matter axonal properties give us a confidence of 80 to 100% accuracy of who is going to become a chronic pain patient. That sort of changes the whole discussion of what is chronic pain from a nociception sort of viewpoint to a neurological viewpoint.
So you've got this finding that you've got an increased connectivity between the nucleus accumbens and the medial prefrontal cortex. Now, how would that relate to chronic pain, and how does one dampen that if you could try to do that as a therapy?
Well, so we think that what that is implying is the actual brain's emotional learning circuitry's response to the peripheral injury. So all these patients have essentially a homogeneous or a similar peripheral injury to start with. Some of these subjects have a much larger functional connectivity between accumbens and the prefrontal cortex, while others don't. And the ones who have a larger connectivity are the ones who are becoming chronic pain patients. So we interpret that result as showing essentially a dopaminergic signal that's heightened, that in a sense there's a heightened emotional uh, attention to the pain, and that attention in turn is reorganizing the brain. That's in general. And that idea is more than just a theory now, because we actually have animal studies that we are doing where we can replicate and find the pieces, the components of that circuitry consistently in animal models as well.
Are you trying to differentiate this at the receptor level between D1 and D2 receptors and D1, D2 receptors?
Yes, exactly. In fact, so we just published a study where in humans where we can differentiate between the core and the shell of accumbens, and showing that in fact the shell is more specific for pain, the core is more specific for reward, positive reward, so what versus pain, and our animal neuropathic injury rats show reorganization of specifically of D2 median spiny neurons in the shell in opposite direction from that of the core, while the D1 neurons seem unchanged. So this is data, in fact, we're going to report at the neuroscience meeting coming up in November.
D2 dopamine receptors usually thought to be linked to inhibitory pathways. So is there a change then in some inhibitory pathway, the inability to inhibit pain? Is that one of the implications of this finding?
I don't know whether it's inhibiting pain or not, but the D2 pathway is being, multiple groups are now showing that the D2 pathway seems to be more specific for aversion learning rather than positive reward learning.
Right.
So it's consistent with that, and yes, the D2 is thought to inhibit even motor responses in a sense, and that is also consistent with the idea that pain is a motor inhibitory response. So in many ways, we now think as to this the whole limbic dopaminergic system as driving the emotional assessment of the pain itself. Another way of saying it is that anytime we are doing anything, a very simple task, walking, for example, activates nociceptors. It has to activate nociceptors just with the amount of weight we put on those nociceptors at the bottom of our feet. We report that as pain. That's part of our almost pleasure in a sense. Yet, when a subject is in this transition state, those nociceptors may have much more value associated with them because of the reorganization of the circuitry. Okay, so some of this is philosophical, and it's not all necessarily completed, but this is the direction at least our thought process is going in the work.
So in the opiate use in chronic pain, are you looking at individuals who are using opiates versus those who are not using opiates? Are you seeing any differences in terms of some of your findings there?
Well, I guess we've tried to avoid opiates for the time being. In fact, we have absolutely not studied opiates at all, for no good reason except that we've been trying to look at what are the mechanisms in the absence of modulation. Obviously, opiates are going to have a huge effect on this circuitry, and we know very little about those details, right? Specifically, in general, about patients with chronic pain. My prejudice is to simplify these studies to something that I can actually, discover something specific and more limited, and we can advance the field. There are lots of questions, and opiates is a big field that needs to be obviously addressed. Right. But once we get some of the basic elements put together, then we would start looking at those questions.
In your patients who do show this essentially predisposition to develop chronic pain syndrome, are you looking at some of the antecedents? Is there a positive family history of addiction or alcoholism, or do any of these individuals have trauma either to themselves or their family? Have there been significant events from an environmental or a genetic standpoint that you're actually chasing down these days?
Well, we haven't done that in a sense that these predisposition signals have caught us by surprise. We had not expected such a big predisposition. This was not. We had not designed the study to actually see this. It's just hit us in a big way, and these are questions we have to start addressing in the next cycle of studies. We have not asked such questions. The design was to capture the pain in as much detail as possible and look at its interaction, the pain interaction with the brain. In our surprise has been that in fact the pain is playing, of course, it's playing an inciting factor, but then all of the other events seem to be driven by central processes. So, which is a big surprise to us. I mean, my prejudice, I'm a student of Pat Wall, and, and I have spent large numbers of my scientific career, looking at nociceptive input from the spinal cord to the thalamus, from the thalamus to the, supraspinal, suprathalamic cortical inputs. Yet those are the signals that in fact are decreasing when the subjects are becoming chronic pain patients, and central processing seems to be overriding them. So our whole thought process of what is chronic pain is, at least in my lab, is going through a big revolution and changing our views of how to even approach these patients.
So what's the next series of experiments?
Well, the next series, in fact, we're just beginning in the next few weeks, in fact, and this is the next cycle, and NIH has funded it, in fact, so it's really exciting, and we are going to essentially replicate this longitudinal study with the treatment. And the treatment will be addressing the dopamine pathways together with peripheral analgesics, and we have animal data showing that if we combine the two together, we get better, at least short-term, post-injury decrease in pain-like behavior in animals, and we're hoping to show that, in fact, so that aggressive treatment early on after an acute back pain event will dramatically decrease the transition from acute to chronic pain. So that's the goal, which will take multiple years, probably 3 to 4 years to be even finished the study. It's a large study. It will take many, many years to collect the data.
All right, well, we'll be waiting for those results when they come out. Thank you for a very interesting presentation today and for coming down and having an interviewing with us.
Thanks.